of each nostril, avoiding contact with the sensitive nasal septum. Hold the otoscope handle to one side to avoid the patient's chin and improve your mobility. By directing the speculum posteriorly, the upward in small steps, try to see the inferior and middle turbinates, the nasal septum, and the narrow nasal passage between them. Some asymmetry of the two sides is normal. Deviated septum, a shifting of the wall that divides the nasal cavity into halves. Nasal polyps, a soft growth that developed on the line of your nose sinus. Nose bleeds. Herpes nasalis. Rhinitis, inflammation of the nose and sinus sometimes caused by allergies. The main symptom is a runny nose. Nasal fractures.
Eyes.
Can you look up, please? It's okay. Can you close your eyes and hold, please? Open, please. It's okay.
Eyes are placed symmetrically, no enophthalmos or exophthalmos. Lids are not edematous, there's no ptosis, chantelasmas, halasium. Stelved sign is negative. No failure or tremor in closing and opening. Other disorders are absent. In conjunctiva, there's no pallor, hyperemia, and petechia. In sclera, there's no jaundice and hemorrhoids. Kaiser-Fleischner ring, pinguecula, pterygium are absent. In iris, there's no arcus senilis. Cornea has no scars, no ulceration. Pupils size and shape are symmetrical. There's no meiosis, midrias, or anisocaria. Argyll-Robertson and Landau-Field sign are negative. Pupils are reacting to light, no Horner sign.
Swing flashing light test is a clinical test for functional impairment in the optic nerves. In dim light, note the size of the pupils. After asking the patient to gaze into the distance, swing the beam of a penlight first into one pupil, then into the other. Normally, each illuminated eye looks or promptly becomes constricted. The opposite eye also constricts consensually. Lead leg. Ask the patient to follow your finger or pencil as you sweep through the six cardinal directions of gaze. Make a wide H in the air. Lead the patient gaze first to the patient's extremity right, second to the right and upright, and third down on the right. Fourth, then without passing the middle to the extremity left. Fifth, to the left and upright, and sixth, down on the left. Passing during upright and lateral gaze to detect nystagmus. Move your finger or pencil at a comfortable distance from the patient. Because middle-aged or older people may have difficult focus on near objects, making this distance great for them and for young people. Some patients move their heads to follow your finger. If necessary, hold the head in the proper midline position. Test for convergence. Ask the patient to follow your finger or pencil as you move it in toward the bridge of the nose. The converging eyes normally follow the object to within 5 cm to 8 cm of the nose. Conjunctiva and sclera. Ask the patient to look up as you depress both lower lids with your thumbs, exposing the sclera and conjunctiva. Inspect the sclera and palpebral conjunctiva for color and note the vascular pattern against the white sclera background. Look for any nodules or swelling. Nuclear cataracts. A nuclear cataract looks gray when seen by a flashlight. If the pupil is widely dilated, the gray opacity is surrounded by a black ring. Through an ophthalmoscope, the cataract looks black against the red reflex. Peripheral cataract. A peripheral cataract produces spoke-like shadows that point inward, gray against black as seen with a flashlight or black against red with an ophthalmoscope. Corneal arcus. A corneal arcus is a thin gray to white arc or cycle not quite at the edge of the cornea. It accompanies normal aging but may also be seen in younger people, especially African Americans. In young people, a corneal arcus suggests the possibility of hyperlipoproteinemia, but does not prove it. Some surveys have revealed not relationship. Corneal scar. A corneal scar is a superficial gray to white opacity in the cornea, secondary to an old injury or to inflammation. Size and shape are variable. It should not be confused with opaque lens of a cataract, visible on a deeper plane or only through a pupil. Pterygium. A pterygium is a triangular thickening of the bulbar conjunctiva that grows slowly across the outer surface of the cornea, usually from the nasal side. Reddening may occur intermittently. A pterygium may interfere with vision as it encroaches upon the pupil. Agies pupil. A tonic pupil is large, regular, and usually unilateral. Its reaction to light is severely reduced and slowed or even absent. The near reaction, though very slow, is present. Slow accommodation causes blurred vision. Deep tendon reflex are often decreased. Oculomotor nerve C and 3 paralysis. The dilated pupil, about 6-7 mm, is fixed to light and near effort. Ptosis of the upper eyelid and lateral deviation of the eye are often but not always present. Horner's syndrome. The affected pupil, thought small, reacts briskly to light and near effort. Ptosis of the eyelid is present, perhaps with loss of swelling on the forehead of the same side. In congenital Horner syndrome, the involved iris is lighter in color than its fellow. Ptosis. Ptosis is a dropping of the upper lid. Causes include myasthenia gravis, damage of the oculomotor nerve, and damage to the sympathetic nerve supply. A weakened muscle, relaxed tissues, and the weight of herniated fat may cause senile ptosis. Ptosis may also be congenital. Equal pupils and one blind eye. Unilateral blindness does not cause anisocoria as long as the sympathetic and parasympathetic nervation to the both irises is normal. A light directing to the seeing eye produces a direct reaction in that eye, and a consensual reaction in the blind eye. A light directing to the blind eye, however, causes no response in either eye. Small, irregular pupils. Small, irregular pupils that do not react to light but do react to near effort indicate Argyll-Robertson pupils. They are usually but not always caused by central nervous system syphilis. Epicanthus. An epicanthus, epicanthal fold, is a vertical fold on skin that lies over the medial canthus. It's normal among many Asian people. These folds are also seen in Down syndrome and in a few other congenital conditions. They may falsely suggest a convergent strabismus. Herniate fat. Puffy eyelids may be caused by fat. It pushes weakened fascia in the eyelids forward, producing bulges that involve the lower lids, the inner third of the upper ones, or both. These bulges appear more often in elderly people but may affect younger ones. Exophthalmos. In exophthalmos, the eyebrow protrudes forward. When bilateral, it suggests the infiltrative ophthalmopathy of Graves' disease, a form of hypothyroidism. Edema of the eyelids and conjunctival injection may be associated. Unilateral exophthalmos may be due to Graves' disease or to a tumor or inflammation of the orbit. Periorbital edema. Because the skin of the eyelid is loosely attached to underlying tissues, edema tends to accumulate there easily. Causes include allergies, local inflammation, cellulitis, mixed edema, and fluoretanic states such as the nephrotic syndrome. Retracted lid. A wide-eyed stare suggests retracted eyelids, in this case the upper lid. Note the ring of sclera between the upper lid and the iris. Retracted lids and a lid lag are often due to hypothyroidism, but may be seen in normal people. The eye does not protrude forward unless exophthalmos coexist. Conjunctivitis. Pattern of redness. Conjunctival injection. Diffuse dilation of conjunctival vessels with redness that tends to be maximal peripherally. Pain. Mild discomfort rather than pain. Vision. Not affected except for temporary mild blurring due to discharge. Ocular discharge. Watery, mucoid, or mucopurulent. Pupil. Not affected. Cornea. Clear. Significancy. Bacterial, viral, and other infections. Allergy, irritation. Corneal injury or infection. Pain, moderate to severe, superficial. Vision, usually decrease. Ocular discharge, watery or purulent. Pupil, not affect unless iritis develops. Cornea, change depends on cause. Significancy, abrasions and other injuries, viral and bacterial infections. Acute iritis. Pain, moderate, etching deep. Vision, decreased. Ocular discharge, absent. Pupil may be small and with time irregular. Cornea, clear or slightly clouded. Significancy, associated with many ocular and systemic disorders. Glaucoma, pain, severe, etching deep. Vision, decreased. Ocular discharge, absent. Pupil, dilated, fixed. Cornea, steamy, cloudy. Significancy, acute increase in intraocular pressure, an emergency. Conjunctival hemorrhage, pattern of redness. Leakage of blood outside of the vessels producing a homogeneous, sharply demarcated red area that fades over days to yellow and then disappears. Pain, absent. Vision, not affected. Ocular discharge, absent. Pupil, not affected. Cornea, clear. Significance, often none. May result from trauma, bleeding disorders, or a sudden increase in venous pressure as from cough. Cataract. A cataract is an opacity of the lens and is seen through the pupil. Cataracts are classified in many ways, including cause and location. Old age is the most common cause. Inflammation of the lacrimal sac. A swelling between the lower eyelid and nose suggests inflammation of the lacrimal sac. An acute inflammation is painful, red, and tender. Chronic inflammation is associated with obstruction of the nasolacrimal duct. Tear is prominent and pressure on the sac produces regurgitation of the material through the puncta of the eyelids. Entropium. Entropium, more common in the elderly, is an inward turning of the lid margin, the lower lashes, which are often invisible when turned inward, irritate the conjunction and lower cornea. Asking the patient to squeeze the lids together and then open them may reveal an entropium that is not obvious. Ectropium. In ectropium, the margin of the lower lid is turned outward, exposing the palpebral conjunctiva. When the punctum of the lower lid turns outward, the eye no longer drains satisfactorily and tear occurs. Ectropium is more common in the elderly. Episcleritis. Episcleritis is a localized ocular redness from inflammation of the episcleral vessel. In natural light, vessels appear salmon pink and are movable over the scleral surface, usually benign and self-limited. Episcleritis may be nodular, or may show only redness and dilated vessel. Halazo. Halazo is a subacute non-tender nodule involving a male Bohmian gland. A beady nodule is an otherwise normal lid. It is usually painless. Occasionally, a halazo becomes acutely inflamed, but unlike a stye, usually points inside the lid rather than on the lid margin. Chantelasma, slightly raised, yellowish, well-circumscribed plaques in the skin. Chantelasmas appear along the nasal portions of one or both eyelids. They may accompany lipid disorders, but may also occur independently. Stye, a painful, tender, red infection in a gland at the margin of the eyelid. A stye looks like a pimple or boil pointing on the lid margin. Pingecula, a yellowish, somewhat triangular node in the bulbar conjunctiva on either side of the iris. A pingecula is harmless. Pingeculae appear frequently with aging, first on the nasal and then on the temporal side. Basal cell epithelioma. Arcus senilis. anisocaria.
Lips. Lips are pinkish in color, scars, fissure, ulceration, cheilitis, angular stomatitis, and herpes are not present. No dryness as well. Mucosa is pink and moist.
Herpes simplex. The herpes simplex virus produces recurrent and painful vesicular eruptions of the lips and surrounding skin. A small cluster of vesicles first develops. As these break, yellow-brown crusts form, and healing ensues within 10 to 14 days. Both of these stages are visible here.
Angular cheilitis starts with softening of the skin at the angles of the mouth, followed by fissuring. It may be due to nutritional deficiency or, more commonly, to overclosure of the mouth, as in persons with no teeth or with ill-fitting dentures. Saliva wets and macerates the enfolded skin, often leading to secondary infection with Candida, as in this example.
Actinic cheilitis. Actinic cheilitis result from excessive exposure to sunlight and affects primarily the lower lip. Fair-skinned men who work outdoors are most often affected. The lip loses its normal redness and may become scaly, somewhat thickened, and slightly everted. Because solar damage also predisposes to carcinoma of the lip. Be alert to this possibility. Leukoplakia. A thickened white patch may occur anywhere in the oral mucosa. The extensive example shown on this buccal mucosa resulted from frequent chewing of tobacco, a local irritant. This kind of irritation may lead to cancer. Angioedema. Angioedema is a diffuse, non-pitting, tense swelling of the dermis and subcutaneous tissue. It develops rapidly and typically disappears over subsequent hours or days, although usually allergic in nature and sometimes associated with hives. Angioedema does not itch. Hereditary hemorrhagic telangiectasia. Multiple small red spots on the lips strongly suggest hereditary hemorrhagic telangiectasia. Spots may also be visible on the face and hands and in the mouth. The spots are dilated capillaries and may bleed when traumatized. Affected people often have nosebleeds and gastrointestinal bleeding.
Peutz-Jeghers syndrome. When pigmented spots on the lips are more prominent than freckling of the surrounding skin, suspect this syndrome. Pigment in the buccal mucosa helps to confirm this diagnosis. Pigmented spots may also be found on the face and hands. Diphtheria. Diphtheria is now rare but still important. Prompt diagnosis may lead to life-saving treatment. The throat is dull red and a gray exudate is present on the uvula, pharynx, and tongue. Torus palatinus. A torus palatinus is a midline bony growth in the hard palate that's fairly common in adults. Its size and lobulation vary. Although alarming at first glance, it's harmless. In this example, an upper denture has been fitted around the torus. Kaposi sarcoma. Deep purple color lesions, raised or flat. Candidiasis. Thick white plaques are somewhat adherent to the underlying mucosa. Marginal gingivitis is common among teenagers and young adults. The gingival margins are reddened and swollen, and the interdental papillae are blunted, swollen, and red. Brushing the teeth often makes the gums bleed. Acute necrotizing ulcerative gingivitis. This uncommon form of gingivitis occurs suddenly in adolescents and young adults and is accompanied by fever, malaise, and enlarged lymph nodes. Ulcers develop in the interdental papillae. Then the destructive process spreads along the gum margins, where a grayish pseudomembrane develops. The red, painful gums bleed easily, the breath is full. Gingival hyperplasia. Gums enlarged by hyperplasia are swollen into heaped-up masses that may even cover the teeth. The redness of inflammation may coexist, as in this example. Causes include dilantin therapy, puberty, pregnancy, and leukemia. Kaposi sarcoma in AIDS. Kaposi sarcoma may appear in the gums as in other structures. The shape of the lesion in this advantaged example might suggest hyperplasia, but the color suggests Kaposi sarcoma. Be alert for less obvious lesions. Dental caries is first visible as a chalky white area in the enamel surface of a tooth. This area may then turn brown or black, become soft, and cavitate. Special dental techniques, including X-ray, are necessary for early detection. Fissured tongue. Fissures may appear in the tongue with increasing age. Their appearance has led to the alternate term scrotal tongue. Although food debris may accumulate in the crevices and become irritating, a fissured tongue usually has little significance. Hairy leukoplakia, white, raised, feathery areas usually on sides of tongue due to HIV infection.
Leukoplakia. A persistent painless white patch in the oral mucosa is often called leukoplakia until biopsy reveals it's natural. Here, the undersurface of the tongue looks as if it had been painted white. Smaller patches are more common. Leukoplakia of any size raises the possibility of malignant change.
Aphthous ulcer, painful small whitish ulcer with head halo. Mucous patch, slightly raised oval lesion covered by a grayish membrane due to secondary syphilis. Varicose veins, dark round spots on the undersurface of the tongue associated with aging. Carcinoma of the tongue, a malignancy that should be considered in any nodule or non-healing ulcer at the base or edges of the tongue.
Ears. Can you turn your red, please? Turn on the side, please. It's okay.
Ears are placed symmetrically, no deformities, keloid, lumps, tophi, creases, scars. Lesions are not visible. More deep examination with otoscopy is necessary.